Welcome back to The Deep Dive. Today, we are really diving in, undertaking something of a high-speed knowledge transfer mission. It's entirely dedicated to transforming these, well, dense clinical guidelines into ready-to-use, razor-sharp facts.
Yeah, cutting through the noise.
Exactly. So if you're a GP trainee gearing up for the AKT exam or, any clinician who really demands that absolute certainty when diagnosing and managing these complex respiratory presentations, this deep dive is specifically tailored for you.
That's absolutely right. Our goal today isn't just to summarize the topics you see everywhere. It's really to extract the core, the non-negotiable data points.
The numbers, the steps.
Precisely. Those precise numerical cutoffs, the mandatory management sequences, and crucially, the differential diagnoses that separate clinical certainty from just guesswork. We're aiming to turn this raw source material into instantly accessible knowledge.
Okay.
Making sure you know not just what to do, but why the rules, the guidelines are set at those specific parameters.
Right. Understanding the why behind the number. So we're jumping straight into the core pillars of primary care respiratory practice then. We're covering everything from the fundamental mechanics of lung function testing.
The basics, yeah.
Spirometry.
To the structured management of chronic diseases like asthma and COPD. And then finishing up with those, acute, potentially life-threatening vascular and infectious scenarios.
Emergencies.
Think of this as your concentrated shot of essential respiratory certainty.
Yeah.
Okay, let's unpack this then, starting right at the absolute foundation, spirometry. Because in primary care, the ability to just instantly categorize a trace, obstructive or restrictive pattern that really guides our immediate next steps, investigation, referral strategy. Yeah. Where do we even begin with the definitive metrics?
Well, you always start with the ratio. That's really the deciding factor between those two main patterns. You've got the forced expiratory volume in 1 second, the FEV1.
Right. And that's always looked at in relation to the forced vital capacity, the FVC. It's that ratio, the FEV1 divided by FVC, that determines the pattern. And then you look at FEV1 on its own to figure out the severity.
Okay, that makes sense. Let's nail down the obstructive pattern first. This is the one where air gets trapped, right? So the flow out is impaired.
Precisely, yeah. Obstructive pattern, your classic examples being asthma and COPD, the air basically has trouble getting out. So the FEV1 itself is significantly reduced.
Okay.
And most importantly, that FEV1-FVC ratio, which we often talk about as a percentage, FEV1%, that's reduced too. The flow is, slow relative to the total volume the lungs can hold.
And here's where that clinical distinction becomes absolutely crucial, isn't it? Because for exams and just for practice, the same underlying numerical threshold for obstruction is used. But the massive differentiator lies in whether it's reversible or not.
Absolutely critical distinction. We're generally looking at that FEV1%, the ratio being less than 70% in both conditions. That's your starting point for obstruction.
Less than 0.7, yeah.
Yeah, right. But if that reduction is reversible, and by reversible we mean the FEV1 increases by at least 12% and 200 milliliters after you give a bronchodilator.
Okay, both criteria needed.
Both, yes. 12% and 200 milliliters. If you see that, you're primarily thinking asthma. If, on the other hand, the FEV1% is less than 70%, and it stays fixed, it's irreversible after that bronchodilator challenge, well, then we define that as COPD.
Got it.
That test, the post-bronchodilator assessment, that is really the watershed moment. It determines whether you start down an ICS-LABA pathway for asthma or maybe a LABA-LAMA pathway for COPD. It dictates the whole management plan.
That makes perfect sense. Okay, now let's flip our focus to the restrictive patterns. This is often where I find confusion can creep in. People sometimes mistakenly assume that if the FEV1 is reduced, it must be obstructive.
Yeah, that's a common trap.
But in restriction, the issue isn't really the flow, is it? It's simply the volume.
That's the critical diagnostic insight. Exactly. In restrictive lung disease, the problem is fundamentally mechanical restriction. Either the chest wall can't expand fully, or the lung tissue itself is stiff, maybe fibrosed.
Right.
And the result of that is that the forced vital capacity, the FVC, is significantly reduced. You just can't get enough total air in the first place.
But because the airways themselves, the structures responsible for flow rates, are basically okay.
Fundamentally intact, yeah.
The air that is inhaled gets exhaled pretty efficiently.
Exactly. The flow rates themselves are fine, maybe even faster than normal in relative terms. But the overall capacity, the volume, is lost. Therefore, that FEV1-FVC ratio is preserved.
Okay.
It typically sits around the predicted normal, often 80% or higher, sometimes even close to 100%. And in some cases, actually, because the FEV1 might be slightly more preserved relative to the drop in FEC, especially in advanced fibrosis, the ratio can actually look supernormal,
Yeah.
over 100%. So seeing a drastically reduced FDC paired with a normal or even high FEV1 FEC ratio should immediately make you think restrictive pathway.
That structural distinction, reduced FVC, but a preserved or high ratio, that's diagnostic gold, really. For pattern recognition and then figuring out the cause, it immediately shifts your thinking away from bronchodilators towards finding these anatomical or maybe neuromuscular causes.
And this causes analysis is absolutely vital, particularly for the AKT exam.
Yeah.
We tend to simplify the differential diagnosis into two big buckets. Problems starting outside the lungs?
Extrathoracic neuromuscular thing.
Exactly. Or problems originating inside the lungs, parenchymal disease.
Right. So give us the high-yield examples that really demand attention in both those buckets. What are we looking for?
Okay, for causes outside the lungs, you're looking for anything that physically stops the chest wall or the diaphragm from moving properly.
Like severe obesity?
Extreme obesity is a major one,
Yeah.
Purely mechanical restriction. Then you've got structural deformities like severe scoliosis or kyphosis, which literally reduce the thoracic volume. And crucially, don't forget neuromuscular conditions. Things like motor neuron disease, MND, or maybe myasthenia gravis. They affect the power of the respiratory muscles, leading to that loss of volume.
Okay, that makes sense. And for causes inside the lungs, these are the conditions making the lung tissue itself stiff, non-compliant.
Yeah, these are the intrinsic parenchymal diseases, primarily characterized by inflammation or fibrosis, which makes the lungs stiff and hard to inflate. Think acute respiratory distress syndrome, ARDS,
Right.
severe pulmonary fibrosis from various causes, or occupational exposures like asbestosis or silicosis. Understanding this sort of binary inside versus outside distinction really helps confirm the diagnosis and points you towards the complex workup that often follows.
Okay, moving now to asthma. This is bread and butter for GPs, isn't it? A condition every clinician manages almost daily, yet sometimes the objective diagnostic criteria get missed, and that can lead to, well, treatment failure.
It really can. It's crucial to get the diagnosis right objectively.
So let's start with the precise diagnostic steps required for adults, people aged 16 and over.
Okay, so diagnosing asthma in adults, it relies on having a high clinical probability based on symptoms, plus getting objective evidence of either variable airflow obstruction or airway hyperresponsiveness.
Right. Need the proof.
Exactly. We rely on 4 major criteria, and typically you need to verify at least one of these objectively.
Let's detail those 4 then, starting with the inflammatory markers, which are becoming more common now.
Yeah, absolutely. The first criterion is looking for evidence of type 2 inflammation. You measure this either with blood eosinophilia count or increasingly with fractional exhaled nitric oxide FeNO.
FeNO, right.
And the specific cutoff for adults is a FeNO level greater than or equal to 50 parts per billion, ppb. This reflects that underlying eosinophilic airway inflammation.
Okay, 50 ppb for adults. FeNO testing is definitely becoming more central. What are the other 3 criteria then?
Okay, secondly, it's the spirometry reversibility test we just talked about.
Yeah.
That increase in FEV1 of 12% and 200 milliliters from the pre-bronchodilator baseline.
Or the predicted normal.
Or, alternatively, a 10% increase from the predicted normal value for that person. That confirms reversibility. Thirdly, demonstrating peak flow variability. This needs the patient to measure their PEF twice daily for 2 weeks.
Right, the diary.
Yeah, the diary. And you're looking for a consistent day-to-day or within-day variability of 20% or more.
Okay.
And finally, this is usually reserved for specialist care when the diagnosis is still uncertain, is bronchial challenge testing, assessing hyperresponsiveness, often using methacholine.
Right, less common in primary care. Now, that covers the standard adult presentation, but we should definitely note the specific pathway for occupational asthma. That requires a slightly different investigative approach, doesn't it?
Absolutely. Occupational asthma, because of its, medical legal implications and the specific trigger involved, it requires serial peak flows. But crucially, they need to be taken both inside and outside the workplace environment.
To show the correlation.
Exactly. To demonstrate that clear correlation between exposure at work and the decline in lung function or symptoms. Yeah. This is a mandatory referral pathway. You can't really manage this solely based on standard spirometry and history in primary care.
Yeah.
Needs specialist input.
Good point. Now, a critical exam trap. The diagnostic criteria for children, specifically that 5 to 16 age group, they diverge slightly from adults.
They do, and it's a really crucial distinction to remember. In children aged 5–16, well, you often find it harder to get reliable peak flow or spirometry just because of technique issues.
Yeah, getting them to do it properly.
Exactly. So the primary reliance shifts much more heavily towards pheno testing. And the cutoff is different. Pheno greater than 35 ppb for this younger group.
35, not 50.
Right, 35 ppb compared to 50 for adults. And crucially, we do not typically rely on eosinophilia as the primary objective test in children the way we might for adults. Yeah. Otherwise, the spirometry and PEF reversibility criteria, that 12% or 200 milliliters from baseline or 10% predicted, and the PEF variability of 20% or more, those remain consistent with the adult standards if you can get reliable readings.
That 35 ppb versus 50 ppb difference, that is exactly the kind of detail you need for instant recall in exams. Okay, so once the diagnosis is confirmed, let's detail the highly structured non-acute management pathway for adults and adolescents, so those aged 12 years and over.
Right, and this pathway has changed quite a bit recently, especially with the introduction of MART maintenance and reliever therapy. The big goal now is to maximize that anti-inflammatory delivery while still providing relief when needed.
Okay. Walk us through the first couple of steps then, focusing on that shift from just as-needed use to regular therapy.
Okay, step one is the initial treatment. That's a low-dose ICS, inhaled corticosteroid, combined with formoterol, that specific LABA taken as method, PRN.
Right, the AR approach.
Exactly, anti-inflammatory reliever therapy. The big benefit here is that every single time the patient reaches for their inhaler because they have symptoms, they're also getting an anti-inflammatory dose. It really helps with compliance.
Makes sense. If control isn't achieved with just PRN use, we move to step 2.
Step 2.
Right.
We keep the same combination, low-dose ICS plus formoterol, but we change the frequency. It's now taken regularly as a maintenance dose, usually twice a day.
Okay.
This is the cornerstone of MART maintenance and reliever therapy.
Mm-hmm.
The patient takes the combo regularly for maintenance, but they can also use the very same inhaler for relief if they get breakthrough symptoms.
Okay, so same inhaler for both. And step 3.
Step 3 is basically just escalating the maintenance dose within that MART strategy. So you move up to a moderate dose ICS plus formoterol, still taken regularly, still using the same device for relief.
Right. Now, step 4 is where we introduce the critical add-on therapies if MART, even at moderate dose, is still not enough.
Yes, exactly. Step 4 requires adding on either an LTRA, leukotriene receptor antagonist like montelukast, or an add-on LAMA, long-acting muscarinic antagonist like tiotropium, often via a separate inhaler like a Respimat.
Okay, one or the other.
Yes, and the clinical instruction here is crucial. You implement a trial of one of these add-ons, typically for about 4 to 8 weeks. You assess the response. If there's no measurable benefit,
You swap
it for the other add-on before you think about escalating further. You don't just stack them initially at this stage. Try one. If no good, try the other.
Got it. Trial, assess, swap if needed. Okay, if the combination of moderate dose MART plus either an LTRA or LAMA still doesn't achieve control, what's next?
That brings us to step 5, and this is generally the point of mandatory referral to secondary care to respiratory specialists.
Right.
At this level, the specialist will consider options like high-dose inhaled steroids, maybe introducing theophylline, though that's less common now due to monitoring needs, or assessing for suitability for specialist biological therapies targeting specific inflammatory pathways.
Throughout this entire 5-step process, consistent objective monitoring is absolutely non-negotiable, isn't it? To prove the treatment's working and check compliance. What tools must we be using?
Yeah, absolutely vital. Every single review must use standardized, validated questionnaires. Things like the Asthma Control Test, ACT, or the Asthma Control Questionnaire, ACQ.
What score are we looking for on the ACT?
On the ACT, a score of 20 or higher generally indicates good control. If the score is below 15, that's usually poor control and needs action.
Okay.
Furthermore, every patient must have a personalized asthma action plan, a PA8. You need to document that. Inhaler technique must be rigorously checked and corrected at every single review. It's amazing how often technique drifts.
Absolutely.
And if any change to the treatment step is made going up or down, the patient's response must be reviewed fairly quickly, usually between 4 and 8 weeks later. We should also consider repeating things like pheno measurements before and after a treatment change. A significant drop in the pheno reading can objectively confirm that the inflammation is responding to the increased treatment.
That attention to detail is so important. Okay, now let's navigate the, slightly more complex landscape of management in children. For the 5 to 11 age group, the ability to actually comply with MART seems to dictate the pathway chosen.
It really does. If the child can reliably understand and use the MART strategy, taking it regularly and also for relief, they generally follow a similar path to adults. Low-dose MART, potentially moving to moderate-dose MART if needed, before considering add-ons like LTRA.
Okay. But what if compliance is an issue, or MART just isn't suitable for that child?
Right. If MART isn't feasible, the alternative pathway opens up. The guidance suggests trying an LTRA first, usually montelukast for about 8 to 12 weeks.
Why LTRA first?
Montelukast often works quite well in children, particularly those who have significant exercise-induced symptoms or allergic rhinitis alongside their asthma. It's an easy tablet to take. So you give that an 8-12-week trial. If that LTRA trial fails to control symptoms, then you move to introducing a combination of low-dose ICS plus Aleba, taken regularly twice daily, BD, combined with a separate SABA, like salbutamol, inhaler for relief. You might then escalate the ICS dose within that combination before referring on.
Right, a more traditional SABA plus ICS-LABA approach. And finally, the really tricky group, the under 5s. Objective testing is almost impossible here, so we're relying heavily on symptom response in these highly structured treatment trials.
Yeah, this is probably the most challenging group to manage confidently. The strategy here is built around a structured trial and withdrawal process.
How does that work?
You start with a trial of a pediatric low-dose ICS, often given via spacer, plus a SABA reliever, again via spacer, used as needed, PRN, sometimes prescribed twice daily, BD, initially to ensure delivery. This trial lasts for 8 to 12 weeks.
Okay, what if symptoms don't improve?
If the child's symptoms don't get better after that 8-12-week trial, you first meticulously check the inhaler technique with the spacer and compliance. Are they actually getting the medicine? If technique and compliance are good, but there's no response, you generally stop the ICS and refer for specialist input because the diagnosis might be wrong or there's something else going on.
Okay. But what if the symptoms do resolve during that initial trial?
Right. If symptoms do resolve, you then actually withdraw the ICS treatment. You stop it completely for about 3 months and just review the child's clinical state based on symptoms.
Interesting. So you stop it to see if it was just a viral wheeze phase.
Exactly. If symptoms recur within that 3-month off-treatment window, that suggests more persistent inflammation, so you restart the low-dose ICS. The next mandatory review point is usually after about 12 months of using the combination therapy successfully.
Okay.
At that 12-month mark, you try stopping the treatment again for 3 months. If symptoms return after this second cessation attempt, the one after 12 months of treatment, well, that indicates a more persistent underlying asthma-like picture.
Right, less likely to be transient.
Yes. And that's the point when you would consider adding an LTRA, montelukast, to the low-dose ICS plus SABA regimen. Then you review the response to that triple combination in another 8-12 weeks. It's a very slow, methodical path designed to confirm the diagnosis over time and ensure the child isn't put on long-term steroids unnecessarily. Okay, now we shift gears from chronic management to, well, crisis management. For both acute asthma and COPD exacerbations, the precision required to triage and manage these safely is just paramount. The numerical thresholds here are absolutely non-negotiable. You have to know them.
Let's start with acute asthma assessment then. We need those specific clinical signs and, importantly, the numerical cutoffs that define a patient's immediate risk level.
Right. We categorize the severity based largely on peak expiratory flow, PEF, measured against their best or predicted normal. Moderate asthma is defined as a PEF between 50% and 75% of best or predicted.
Okay, 50 to 75%.
Yeah. Symptoms usually involve being able to talk. Maybe not in full, long sentences, but they can talk. Management can often start effectively in the community or GP surgery.
But below 50% PEF, we're entering the territory of severe and life-threatening asthma. This demands immediate, aggressive intervention. What are those definitive, must-know, life-threatening criteria?
This list, you just have to commit it to memory. It includes PEF less than 33% of predicted or best.
Less than a third. Okay.
SpO2 oxygen saturation less than 92%. Any sign of a silent chest.
Terrifying sign.
Yeah, a truly terrifying sign of catastrophic airflow failure. Also, altered consciousness, confusion, signs of exhaustion, cyanosis, blue lip stung, or low blood pressure or hypotension. Any one of these puts the patient in the life-threatening category.
And crucially, there are those pediatric-specific age-dependent heart rate and respiratory rate cutoffs. They often come up as major red flags in exams.
Yes, these are absolutely critical because children often compensate hemodynamically right up until the point of sudden collapse. You need to know the numbers.
What are they?
For children aged 1 to 5 years, a heart rate greater than 140 beats per minute or a respiratory rate greater than 40 breaths per minute flags severe or life-threatening status.
Okay, 140 and 40 for the little ones.
Yes. For children older than 5, the rates are slightly lower, but still very high. Heart rate greater than 125 BPM or respiratory rate greater than 30 breaths per minute. Missing these absolute thresholds means potentially missing the child who is about to arrest.
Right. And what's the standard immediate management in the community, say by the GP or the paramedics before transfer to hospital?
Okay, immediate high-flow oxygen is the first step, aiming for SATs 94-98%. Then, high-dose salbutamol and ipratropium nebulizers, often given back-to-back or even continuously depending on the severity and response.
Okay, nubs straight away. And steroids.
Crucially, yes, immediate oral steroids. PO prednisolone, 40 to 50 milligrams once daily for 5 days, is the standard adult course, often given straight away by the GP or paramedic on scene. For kids, the dose is weight-based, typically 1-2 milligrams up to a max dose.
And admission.
All severe or life-threatening cases must be admitted to hospital, even if they seem to initially respond well to treatment in the community. The risk of relapse is just too high. Moderate cases might be manageable at home if response is good and follow-up is secure, but the threshold for admission should be low.
Okay, clear pathway. Switching gears now to COPD. Let's quickly review the official grading scale based on spirometry, the GOLD-E stages, as it defines prognosis and often treatment eligibility.
Right. The GOLD-E stages classify COPD severity based purely on the post-bronchodilator FEV1 percentage. Remember, the FEV1-FVC ratio has to be below 0.7 or 70% to even diagnose COPD in the first place.
Okay, so assuming FEV1, FVC 0.7.
Yes. Then stage 1 mild COPD is FEV1 greater than 80% predicted. Stage 2 moderate is FEV1 between 50% and 79% predicted. Stage 3 severe is FEV1 between 30% and 49%. And stage 4, very severe, is FEV1 less than 30% predicted.
Got it. Mild 80, moderate 50-79, severe 30-49, very severe 30. But FEV1 alone doesn't really capture the patient's functional disability, does it? For that, we use the MRC scale for breathlessness.
Yes, exactly. The MRC, Medical Research Council Dyspnoea Scale, is essential for assessing the impact on the patient's life and for determining things like suitability for pulmonary rehabilitation programs. It's incredibly practical.
So grade 1.
Grade 1 is breathlessness only on strenuous exercise. Grade 2 means the patient gets short of breath when they're hurrying on the level or walking up a slight hill. Grade 3 is a really major clinical marker.
Why is that?
Because grade 3 means the patient walks slower than other people their own age on the level because of breathlessness, or they have to stop for breath when walking at their own pace on the level. It signifies a real impact on daily activity.
Okay. And what about the higher grades, 4 and 5?
Grade 4 indicates pretty significant functional impairment. The patient has to stop to catch their breath after walking just 100 meters or so, or after only a few minutes on level ground. And grade 5 is the most severe.
Yeah.
The patient's too breathless to leave the house, or they become breathless just when dressing or undressing. These MRC grades must be meticulously documented at reviews. They really inform prognosis and decisions about supportive care, like oxygen or rehab.
Makes sense. Now, on to stable COPD long-term management. The pathway here differs quite a bit from asthma, doesn't it? The goal isn't just bronchodilation, but also minimizing lung hyperinflation and, really importantly, reducing exacerbation frequency.
That's right. The initial management for pretty much everyone diagnosed is access to a short-acting bronchodilator for PRN relief, either a SABA, short-acting beta agonist like salbutamol, or a SAMA, short-acting muscarinic antagonist like ipratropium.
Okay, reliever first. How do we escalate from there?
The escalation really depends on the patient's main problem. Are they primarily troubled by persistent breathlessness, or are they suffering from frequent exacerbations? The pathways diverge slightly.
Okay, let's take the breathless patient first. What's the progression?
For persistent breathlessness, after starting a sebasama, we usually step up to regular use of a single long-acting agent, typically a LABA, long-acting beta agonist, or a LAMA, long-acting muscarinic antagonist.
One or the other?
Yes. If breathlessness still persists, despite regular use of one long-acting bronchodilator, the next step is usually dual bronchodilation, combining a LABA plus a LAMA, often in a single combination inhaler.
Okay, LABA plus LAMA for breathlessness. Now, what if the patient's main issue is frequent exacerbations, maybe those with features suggesting an asthmatic overlap component?
Right. If the patient is having frequent exacerbations, typically defined as 2 or more moderate exacerbations or 1 severe exacerbation requiring hospitalization per year, especially if they have features suggestive of steroid responsiveness like a history of asthma, high blood eosinophil counts, or significant variability in symptoms.
Then ICS comes into play.
Then you consider adding an ICS inhaled corticosteroid to the LABA. So the step up would be to a LABA plus ICS combination inhaler.
Yeah, okay. And if they are still exacerbating or remain breathless on LABA plus ICS or on LABA plus LAMA,
Then you escalate to triple therapy. That's LABA plus LAMA plus ICS, usually delivered via one or sometimes two inhalers. That's the maximal inhaled therapy for most patients.
this brings us to a really crucial warning, a key exam point and a major safety issue. Using ICS on its own in COPD.
Yes, this is a golden rule you must remember. Inhaled corticosteroids must not be used as monotherapy in COPD. Never prescribe just an ICS for COPD.
Why is that?
It must always be combined with the LABA. The clinical insight here, supported by lots of trial data, is that while ICS does reduce inflammation, using it alone in COPD, especially in patients without significant eosinophilic inflammation, consistently increases the patient's risk of developing pneumonia.
Right, significant side effects.
Yes. So if you are using an ICS in a COPD patient, it absolutely must be part of a combination therapy, either LABA plus ICS or triple therapy, LABA plus LAM plus ICS.
Okay, very clear. Let's discuss the highly specialized add-on therapies now. The criteria for starting long-term oxygen therapy, LTOT, are extremely specific and numerical, aren't they?
Yes, LTOT is a significant commitment. It requires oxygen delivery for at least 15 hours per day, ideally including overnight. Its main purpose is to combat the long-term complications of chronic severe hypoxia, like pulmonary hypertension and secondary polycythemia.
So, what are the strict criteria? Who gets it?
The criteria are based on arterial blood gas measurements when the patient is stable. We offer LTOT if their resting arterial partial pressure of oxygen, PO2, is consistently less than 7.3 kPa.
Okay, less than 7.3 kPa, or based on SATs.
Or if blood gases aren't available or practical, if their resting oxygen saturation, PO2, is consistently less than or equal to 88% when stable. Some guidelines use less than 92% as a trigger for formal ABG assessment.
Right. Are there scenarios where we might offer it even if the PO2 is slightly higher than 7.3?
Yes, there's a second group. We also offer LTOT if the PO2 is slightly higher, between 7.3 and 8.2 kPa, but only if the patient also has evidence of complications arising from that chronic hypoxia, such as polycythemia, a high hematocrit, clinical signs of right heart failure, often called cor pulmonale, like peripheral edema or raised JVP, evidence of pulmonary hypertension on echo, or significant nocturnal hypoxia confirmed by overnight oximetry.
And the absolute contraindication.
Critically, LTOT should never be offered to a patient who is an active smoker.
Yeah.
The fire risk is just too high, and frankly, it's largely futile if they continue the lung damage from smoking. They must stop smoking first.
Makes sense. The other key prophylactic measure we sometimes use is azithromycin for those frequent exacerbators. This needs a really thorough pre-treatment workup, doesn't it?
Yes, that workup is absolutely mandatory before starting long-term, low-dose azithromycin, typically 250 milligrams 3 times a week. This is because of the risks of promoting antibiotic resistance and potential cardiovascular side effects.
So what's on the checklist before you prescribe?
Before initiating prophylactic azithromycin, the clinical checklist requires confirmation that the patient has completely stopped smoking. They must continue to have frequent exacerbations despite being on optimal inhaled therapy, usually triple therapy. And you need specific screening tests.
Like?
A CT scan of the chest is often recommended to rule out underlying structural disease like bronchiectasis, which might need different management. Sputum culture is essential to check for non-tuberculous mycobacteria or other resistant organisms. You need baseline liver function tests, LFTs. And, very importantly, a baseline ECG to check the QT interval.
Why is that QT interval check so vital with azithromycin?
Because azithromycin, like other macrolide antibiotics, has the potential to prolong the QT interval on the ECG. This significantly increases the risk of a potentially fatal ventricular arrhythmia called torsades de pointe.
Right, dangerous rhythm.
Very dangerous. So in patients who already have a prolonged QT, or have significant heart disease, or are taking other medications known to prolong the QT interval, the risk is much higher, and azithromycin might be contraindicated or require very careful monitoring.
Okay. Finally, for this section, what's the immediate standard treatment for an acute COPD exacerbation, assuming it looks infective?
Okay, first steps are always to increase the dose and frequency of their short-acting bronchodilator, SABA or SAMA. Get them using it much more often. Then we start oral steroids, Prednisolone, 30 milligrams once daily for 5 days is the standard course for COPD exacerbations.
30 milligrams for 5 days. Shorter than asthma.
Yes, 30 milligrams for 5 days. Evidence shows this is usually sufficient for COPD. Then, if there are signs of a bacterial infection classically, increased sputum volume, change in sputum color to purulent, green-yellow, and maybe increased breathlessness or fever, we initiate antibiotic.
And the choices?
The difficult first-line choices are amoxicillin 500 milligrams 3 times a day, TDS, for 5 days. Or, if penicillin allergic or based on previous sputum results, doxycycline, usually 200 milligram loading dose on day 1, then 100 milligrams once daily for the remaining 4 days. Or clarithromycin 500 milligrams twice daily for 5 days. The choice really depends on local resistance patterns, patient allergies, and previous microbiology if available.
Right. This section delivers some really crucial information for primary care practice, setting accurate patient expectations. We need those exact recovery timelines, don't we? To provide confident advice, manage expectations, do that how long until I feel better, chat properly. It really helps prevent antibiotic overuse and unnecessary repeat consultations.
Absolutely. These benchmarks are just essential for day-to-day clinical practice. We need to be specific with patients. For acute otitis media, ear infection, typically 4 days for symptoms to start improving.
Okay, 4 days for ears.
Sore throat or pharyngitis, usually about 1 week. The common cold, well, that often takes 7 to 10 days to resolve fully.
And the big one, the cough.
Yeah, the critical one is the acute cough or bronchitis. Even when it's clearly viral, that cough often lasts up to 3 weeks.
3 weeks.
3 weeks. If you can confidently tell patients that a cough lasting 3 weeks is often perfectly normal after a virus, you dramatically reduce your antibiotic prescribing rate because patients feel reassured it's not something sinister needing antibiotics.
That's a really useful number to have. What about acute rhinosinusitis? That has its own specific timeline for intervention, doesn't it?
Yes, acute rhinosinusitis, inflammation of the nose and sinuses, can be viral or bacterial, and typically the symptoms can persist for quite a while, maybe 14 to 18 days in total.
Okay. When do we think about antibiotics?
The critical timeline for considering antibiotics is really if symptoms persist beyond 10 days and are severe, like high fever, purulent discharge, facial pain, or if the patient's symptoms initially improve but then significantly worsen again after 5-7 days. That suggests a bacterial superinfection.
Right, the double sickening.
Exactly. In those specific cases, persistent beyond 10 days and severe, or double sickening, the first-line treatment is usually phenoxymethylpenicillin, MVD, or maybe doxycycline or coamoxicleb, depending on severity and local guidance, usually for 5 days. For most cases, which are viral, nasal saline washes and maybe short-term nasal steroids offer the best symptomatic relief.
Okay. Now, pneumonia recovery, as we kind of touched on earlier, it's often a really prolonged process, isn't it? Especially for older people or those with other health problems. How do we break down the recovery phases when we're counseling patients?
Yeah, it's important to set expectations realistically. We usually counsel them using these benchmarks. The fever, if they had one, should resolve within about 1 week. The chest pain and the initial really heavy sputum production usually start to abate within about 4 weeks.
Okay.
But the lingering symptoms, particularly the cough and the feeling of breathlessness, they may well persist for up to 6 weeks.
6 weeks for cough and breathlessness.
Yeah. And the most prolonged symptom is often fatigue. Significant fatigue can easily last for 3 months. And the patient might not feel entirely back to their pre-illness baseline, their normal energy levels, for a full 6 months.
6 months for full recovery. Wow.
Yeah. That's why a 6-week post-illness check, often including a repeat chest x-ray, is important to ensure resolution and rule out any underlying persistent pathology like malignancy that might have been masked by the infection.
Good point. Now, on to diagnosing and managing community-acquired pneumonia, CAP. Triage and the initial management decisions are almost entirely governed by the CURB-65 score. Let's detail the components again.
Right. CURB-65 is that rapid risk stratification tool we use at the bedside or in the surgery. C stands for new confusion, often defined as an abbreviated mental test score, AMTS, of 8 or less, or any new disorientation in time, place, or person.
Okay, C for confusion.
U. U is for urea, a raised serum urea level, typically greater than 7 millirel.
Okay.
R is respiratory rate, a high rate, specifically greater than or equal to 30 breaths per minute. B is blood pressure, low blood pressure, either systolic less than 90 mmHg or diastolic less than or equal to 60 mmHg.
And the 65.
And 65 is simply age greater than or equal to 65 years. Each of those components scores 1 point, giving a total score from 0 to 5.
Okay, CURB 65, and how does that score directly dictate our management, especially the decision about hospital admission?
It's pretty prescriptive. A CURB 65 score of 0 is generally considered low risk. These patients can usually be treated safely at home with oral antibiotics, typically amoxicillin 500 milligram TDS for 5 days, provided they're otherwise stable, can take oral meds, and have adequate support at home.
Okay, score 0, home with amoxicillin. What about 1 or 2?
A score of 1 or 2 suggests moderate severity. Here, the guidance says we must consider hospital admission. The decision depends on clinical judgment factors like oxygen saturation, comorbidities, social support. If treated as an outpatient, they usually need dual antibiotics like amoxicillin plus clarithromycin or doxycycline if penicillin allergic to cover typical and atypical pathogens. If admitted, they'll likely get IV versions.
Right, so 1-2 is the consider admission group, often needs broader cover, and a score higher than 2.
Any score of 3 or more, so 3, 4, or 5, is classified as severe CAP and indicates high mortality risk. These patients require urgent hospital admission, often needing intensive monitoring, IV fluids, oxygen, and prompt IV antibiotics. Typically, coamoxiclav plus clarithromycin is a common combination.
That dual therapy again, covering pneumococcus and the atypicals. What if the patient has a severe penicillin allergy, say anaphylaxis? How does that change the antibiotic choice for moderate or severe CAP?
Yeah, that's a really common clinical scenario you need to be ready for. If there's a convincing history of severe penicillin allergy, you obviously can't use amoxicillin or coamoxiclav. For moderate CAP, CURB 1 to 2, you might use doxycycline plus clarithromycin. For severe CAP, CURB 3 plus, options might include a quinolone, like levofloxacin, which covers both typicals and atypicals, or perhaps a third-generation cephalosporin, like ceftriaxone if the allergy isn't cross-reactive, plus clarithromycin. The key is ensuring you still cover both Streptococcus pneumonia and the atypical pathogens like Legionella and Mycoplasma. Local hospital guidelines are crucial here.
Right. Let's talk a bit more about those atypical pneumonias. They are really high yield for exams because they often present with distinctive non-respiratory features alongside the chest infection.
Yes, the systemic pointers are absolutely the key to unlocking these diagnoses. If you see a patient with pneumonia plus an associated skin rash, particularly erythema multiforme, those target lesions, think Mycoplasma pneumonia. Mycoplasma pneumonia is often associated with bilateral, patchy consolidation on the chest X-ray, and it can sometimes cause other weird things like cold agglutinin disease leading to hemolytic anemia, or even neurological symptoms like encephalitis or Guillain-Barré syndrome.
Okay, mycoplasma and erythema multiforme. What about the other classic pairing pneumonia linked to an electrolyte disturbance?
Right. If you see pneumonia, particularly if it looks quite severe, plus hyponatremia, low serum sodium,
Must think Legionella.
you must immediately suspect Legionella pneumophila. This organism often causes a more severe pneumonia, sometimes with confusion, diarrhea, and deranged LFTs. Crucially, it can cause hyponatremia due to inducing SIADH, the syndrome of inappropriate antidiuretic hormone secretion.
And how do we confirm Legionella?
The diagnosis is often confirmed rapidly using a urinary antigen test for Legionella pneumophila serogroup 1, which is the most common cause. Treatment usually involves a macrolide like clarithromycin or azithromycin, or a quinolone like levofloxacin. We should also briefly mention chlamydia pneumonia or chlamydophila, which often causes a less severe, sometimes called walking pneumonia, often in younger adults.
Okay. Finally, for infections, let's contrast that community-acquired approach with hospital-acquired pneumonia, HAP. The definition is time-based, isn't it? And the management reflects the increased risk of resistant bacteria.
Exactly. HAP is defined specifically as a pneumonia that develops 48 hours or more after hospital admission.
Okay, 48 hours is the key.
Yes. Because these patients have been exposed to the hospital environment, the risk of infection with more resistant pathogens like gram-negative organisms, E. Pseudomonas, Klebsiella, or Staphylococcus aureus, including MRSA, is significantly higher than in CAP.
So the first-line treatment needs to be broader.
Generally, yes. The first-line treatment is typically broader than for CAP. Often, empiric treatment might be with something like coamoxiclav, piperacillin tazobactam, Pip-Taz, or a broad-spectrum cephalosporin, usually for 5 to 7 days. The exact choice depends heavily on local hospital guidelines, severity, and patient risk factors for resistance.
And if the infection is severe or if MRSA or Pseudomonas is specifically suspected.
If the HAP is severe, or if the patient has specific risk factors for MRSA, like previous MRSA colonization, or Pseudomonas, like structural lung disease, gas bronchiectasis, then treatment must escalate quickly. This might involve adding vancomycin or teicoplanin to cover MRSA, or using specific anti-pseudomonal agents like piptaz, ceftazidime, meropenem, or ciprofloxacin, often guided by early microbiological results and local antibiotic stewardship policies. Okay, this next section represents a really critical synthesis of knowledge, I think. It's about connecting the dots between underlying autoimmune conditions, genetic predispositions, environmental exposures, and how they manifest in the lung parenchyma, causing interstitial lung diseases, ILDs. These are complex for sure, but pattern recognition is absolutely essential.
Let's start with the most common ILD, idiopathic pulmonary fibrosis, IPF, or pulmonary fibrosis, PF more broadly. What are the defining clinical signs and radiological signatures we really must recognize?
Clinically, the classic triad you're listening and looking for is crucial. Digital clubbing, that bulbous enlargement of the fingertips, a persistent, dry, non-productive cough. And on auscultation, characteristic fine and inspiratory crackles, often described as sounding like Velcro being pulled apart, typically heard best at the lung bases, bibasal crepitations.
Okay, clubbing, dry cough, Velcro crackles, and radiologically. On CXR or CT?
Radiologically, particularly on high-resolution CT, HRCT, which is the gold standard, we look for bilateral interstitial shadowing. Early on, this might appear as a diffuse ground glass appearance, which can suggest active inflammation. Later, as fibrosis progresses, you see irreversible changes like traction bronchiectasis, dilated airways pulled open by surrounding fibrosis, and in the end stage, honeycombing, these clusters of cystic air spaces, usually in the periphery and bases, representing destroyed lung tissue.
The prognosis, unfortunately, remains quite sobering, doesn't it? But what are the modern disease-modifying options that are available now?
Yeah, unfortunately, the prognosis for IPF specifically is still poor. The typical median life expectancy from diagnosis is only around 3 to 5 years without intervention. Management historically focused on supportive care symptom relief, for example, cough suppressants, pulmonary rehab, oxygen therapy when needed.
But there are drugs now.
Yes, thankfully, we do now have 2 key disease-modifying agents that have been shown in trials to slow the rate of lung function decline in IPF. These are pirfenidone, which has complex antifibrotic and anti-inflammatory properties, and nintedanib, which is a tyrosine kinase inhibitor targeting pathways involved in fibrosis.
Important to note, they slow decline, they don't cure.
Exactly. These medications delay progression. They do not reverse existing fibrosis or cure the disease. They're usually initiated and managed by specialist ILD centers.
Okay. Now, perhaps the single most crucial point for complex differential diagnosis, especially in the exam setting, is differentiating the causes of pulmonary fibrosis based on the location of the disease within the lungs specifically, upper lung zone versus lower lung zone predominance. Why does this location matter so much?
The location often provides immediate, strong clues to the underlying etiology. It relates to how the offending agents, like inhaled dusts, are deposited, or how specific immune responses are distributed in the lung. Conditions typically associated with upper lung zone fibrosis often relate to inhaled dusts that tend to settle higher up due to airflow dynamics or specific granulomatous processes that favor the upper lobes.
Right. Give us the high-yield upper lung fibrosis causes we need to remember. Is there a mnemonic?
Yeah, a common mnemonic for upper lobe fibrosis is C-stars, or a similar variant. So, C for coal-workers pneumoconiosis, S for silicosis from silica dust, T for tuberculosis, especially post-primary or reactivation TB, A for ankylosing spondylitis, a rare but classic association, R for radiotherapy, if the upper chest was in the field, and S for sarcoidosis, which often presents with hilar lymphadenopathy but can cause upper lobe fibrosis later.
C-stars. Got it. Coal, silica, TB, ink spond, radiation, sarcoid, okay? And conversely, the lower lung zone predominant fibrosis causes. These often point towards systemic rheumatological conditions, don't they?
Yes, exactly. Lower lung causes tend to involve processes affected by gravity or specific immune attacks on the peripheral alveoli. The mnemonic often used here is RAAS or similar. R for rheumatoid arthritis RA is strongly associated with lower lobe predominant ILD. A for asbestosis from asbestos fiber inhalation. S for scleroderma or systemic sclerosis. And the other A could stand for idiopathic pulmonary fibrosis itself, previously called cryptogenic fibrosing alveolitis, CFA, which classically affects the lower lobes and periphery.
ROAS, rheumatoid, asbestosis, scleroderma, IPF, CFA. It's essential to remember to ask about asbestos exposure, isn't it? Even if it was decades ago.
Absolutely crucial. The latency period between asbestos exposure and the development of asbestosis or mesothelioma could be 20, 30, even 40 years or more. Always ask about past occupations, construction, shipbuilding, insulation work, etc.
Right. Let's delve a bit deeper into sarcoidosis now. It's such an interesting multi-system granulomatous disease with some very specific findings.
It really is. Sarcoidosis is defined pathologically by the presence of non-caseating granulomata, these collections of inflammatory cells in affected tissues. Clinically, it can affect almost any organ system.
What are the high-yield features we should look for?
Okay, key features to remember. In the chest, bilateral hilar lymphadenopathy on chest X-ray is the classic finding, often symmetrical, sometimes described as potato nodes.
Okay.
Skin manifestations are common, particularly erythema nodosum, those tender red nodules, usually on shins. Eye involvement, uveitis, is also common. And there are specific metabolic features, notably hypercalcemia.
Right, the high calcium. Why does hypercalcemia occur in sarcoidosis? What's the mechanism?
It's quite specific. The granulomas themselves contain activated macrophages. These macrophages possess the enzyme 1-alpha hydroxylase, which is usually found mainly in the kidney. This enzyme converts inactive vitamin D, 25-hydroxyvitamin D, into its active form, 1025-dihydroxyvitamin D calcitriol, independent of normal regulation by parathyroid hormone. This excess active vitamin D then leads to increased absorption of calcium from the gut, hence the hypercalcemia. It can sometimes be the presenting feature, causing symptoms like confusion, constipation, or kidney stones.
Fascinating mechanism. And treatment.
Treatment varies widely. Many cases, especially those just presenting with bilateral hilar lymphadenopathy without symptoms, Lufgren syndrome, often with EN and arthritis, resolve spontaneously over months to years, so observation might be appropriate. However, for progressive lung disease, eye involvement, cardiac sarcoid, neurosarcoid, or persistent hypercalcemia, treatment with oral corticosteroids is usually required, sometimes followed by longer-term immunosuppressants like methotrexate or azathioprine.
Okay. Next up, cystic fibrosis, CF. A profound genetic disorder impacting multiple systems, primarily due to thick secretions.
Yes, CF is an autosomal recessive condition. It results from mutations in the CFTR, cystic fibrosis transmembrane conductance regulator gene, which is located on chromosome 7.
Right, chromosome 7.
This gene codes for a protein that functions as a chloride channel on the surface of epithelial cells. Defective CFTR protein leads to faulty chloride and water transport across cell membranes, resulting in abnormally thick, sticky mucus secretions in the lungs, pancreas, liver, intestines, and reproductive tract.
What are the key clinical clues that should trigger CF investigation, maybe even in an older child or young adult who wasn't picked up on newborn screening?
Well, in newborns, the classic clue is meconium ileus, a bowel obstruction caused by thick meconium failing to pass. In older children or young adults, red flags include recurrent chest infections, chronic cough with thick sputum, failure to thrive or poor weight gain despite a good appetite, and signs of pancreatic insufficiency like bulky, fatty, foul-smelling stools, steatorrhea. Sometimes rectal prolapse can occur due to straining.
And fertility issues.
Yes, in males, infertility or subfertility is very common, occurring in about 95% of men with CF due to congenital bilateral absence of the vas deferens, CVAVD. Females can also have reduced fertility. Diagnosis is usually confirmed via the sweat test, which measures elevated chloride levels in sweat. Genetic testing confirms the specific CFTR mutations.
And the long-term management is incredibly intensive, isn't it? Requiring a big, multidisciplinary team effort, especially regarding infection control in the lungs.
Management is hugely intensive and lifelong. It involves mandatory regular chest physiotherapy and airway clearance techniques, like postural drainage, PP masks, deep breathing exercises, often several times every single day, to help clear the thick lung secretions.
And nutritional support.
Crucial. Pancreatic enzyme replacement therapy, POT capsules, must be taken with every meal and snack containing fat to aid digestion and absorption. Patients need a high-calorie, high-fat, high-salt diet to compensate for malabsorption and increased energy expenditure. Fat-soluble vitamin supplements, A, D, E, K, are also essential.
And the common bugs causing lung infection.
In terms of infection, this is a major focus. The two most common colonizing organisms that cause chronic lung damage are Staphylococcus aureus, often seen in younger patients, and then Pseudomonas aeruginosa, which typically becomes the dominant pathogen later and is associated with accelerated lung function decline. Managing these infections requires aggressive, often long-term, inhaled, and sometimes intravenous antibiotic therapy.
Okay. Let's quickly run through those specific environmental exposures that cause extrinsic allergic alveolitis, EAA, also known as hypersensitivity pneumonitis. These are classic occupational exposure traps for exams.
Right. EAA is essentially an immune-mediated lung disease, a type 3 and type 5 hypersensitivity reaction, caused by repeated inhalation of various organic dusts or chemicals. You need to know the specific pairings of exposure and the resulting condition.
Give us the main ones.
Okay, the classics are mushroom worker's lung, caused by inhaling spores from thermophilic actinomycetes found in mushroom compost. Farmer's lung, probably the most famous one, resulting from exposure to moldy hay or grain containing spores of Saccharopilospora rectivirgula, formerly Micropilospora fani.
Okay, mushroom workers, farmer's lung. What about birds?
Bird fancier's lung, or pigeon breeder's lung, caused by inhaling avian proteins found in bird droppings or bloom, the dust from feathers. There are many others too, like malt worker's lung from Aspergillus species, bagasosis from moldy sugarcane fiber, etc. The crucial first step in management is identifying the offending antigen and ensuring complete avoidance. Corticosteroids are used for acute or severe episodes.
Good list. Finally, for this section, what's the absolute red flag clinical scenario that should make you strongly consider alpha-1 antitrypsin A1AT deficiency?
The profile is really quite specific and should jump out at you. It's typically a young patient, often under the age of 50, who presents with symptoms and spirometry findings of COPD, particularly emphysema.
But they're a non-smoker.
But they are a non-smoker or have only a minimal smoking history. That combination early onset coped emphysema in a non-smoker is the major red flag for A1AT deficiency. The emphysema is often described as panisonar and predominantly affecting the lung bases, unlike the centrilobular upper lobe predominant emphysema usually seen in smokers.
And it affects the liver too, right?
Yes, that's the other crucial link. Alpha-1 antitrypsin protein is produced in the liver. In A1AT deficiency, the abnormal protein can accumulate in liver cells, leading to liver damage. So patients with A1AT deficiency are also at increased risk of neonatal hepatitis, chronic liver disease, cirrhosis, and hepatocellular carcinoma. Checking LFTs is paramount, and measuring the serum A1AT level confirms the diagnosis.
Okay, let's transition now into some high acuity diagnoses and also preventative medicine. These are areas where rapid, accurate clinical judgment is absolutely non-negotiable. Starting with pulmonary embolism, PE. We need to be able to rattle off those critical risk factors, the things that make us think PE. Classic Virchow's triad elements, really.
Yeah, the risk factors are numerous, but the really high-risk triggers need to be flagged immediately in any patient presenting with suggestive symptoms like acute breathlessness or pleuritic chest pain. These include a previous history of VTE, venous thromboembolism DVT or PE. Active cancer, especially during chemotherapy, is a major risk. Recent major surgery, particularly orthopedic or abdominal pelvic surgery. Prolonged immobility, think long-haul flights, bed rest, or hospitalization.
And things we see commonly in primary care.
Absolutely. Combined oral contraceptive pill, COCP use, hormone replacement therapy, HRT, pregnancy, and especially the postpartum period up to 6 weeks after delivery. And of course, any known underlying thrombophilia, inherited clotting disorder. Obesity is also a significant risk factor.
Right. Examination signs can be quite subtle, can't they? Especially in smaller PEs. But what are the key respiratory and cardiovascular signs we might find, particularly in a massive PE causing hemodynamic compromise?
Yeah, often the signs are nonspecific. The patient will typically be tachycardic, fast heart rate, and tachypnoic, fast respiratory rate.
Right.
They might have unexplained hypoxia, low oxygen sats. Pleuritic chest pain might cause shallow breathing. In a more severe, massive PE that's causing significant right ventricular strain.
What might we hear or see?
You might detect cardiovascular signs reflecting that strain. Perhaps a gallop rhythm, an audible third or fourth heart sound, S3 or S4. Raised jugular venous pressure, JVP, indicating right heart backup. Maybe a loud P2 component of the second heart sound, or even a widely split second heart sound due to the increased pressure in the pulmonary artery delaying pulmonic valve closure. Low blood pressure, hypotension is a very ominous sign indicating imminent cardiovascular collapse.
Okay. The diagnostic management pathway is now heavily protocolized, isn't it? Entirely governed by risk stratification using the 2-level Wells score for PE.
That's right. The first step is calculating the Wells score based on clinical signs, symptoms, and risk factors. If the Wells score is calculated as 4 points or more, using the 2-level version, then PE is considered likely.
Okay. Score equals 4, PE likely. What happens then?
In the PE likely pathway, we generally bypass the D-dimer test. These patients should proceed directly to definitive imaging. The gold standard is a CTPA, CT pulmonary angiogram.
Unless contraindicated.
Yes, if CTPA is contraindicated, CD severe renal impairment, preventing contrast use, contrast allergy, sometimes pregnancy, the alternative is a VQ scan, ventilation perfusion lung scan. Critically, patients in the PE likely group should usually be started on interim anticoagulation immediately while awaiting the scan results, unless they have a very high bleeding risk. Often this means admission.
Okay. And what if the Wells score is less than 4, so PE unlikely?
If PE is deemed unlikely, Wells score 4, then we use the rule-out power of the D-dimer blood test. This test measures fibrin degradation products and is very sensitive for VTE.
So if the D-dimer is negative...
If the D-dimer is negative, below the local laboratory threshold, and the test was done appropriately, ideally within 4 hours of presentation, we can effectively and safely rule out PE in this low-risk group. No further imaging is needed.
But if it's positive?
If the D-dimer is positive in the PE unlikely group, it doesn't confirm PE, as it can be raised in many other conditions, but it means we cannot rule it out. So a positive D-dimer in this group means the patient then needs to proceed to definitive imaging, usually CTPA.
Right. There's been talk about age-adjusted D-dimer thresholds, too.
Yes, that's an important clinical update. We know D-dimer levels naturally increase with age, leading to more false positives in older patients. So for patients over 50, using an age-adjusted D-dimer threshold, typically calculated as age by 10 ng/ml, though check local lab units, can help reduce unnecessary imaging while maintaining safety.
Good tip. Regarding anticoagulation then, once PE is confirmed, what's the current standard of care for treatment and duration?
Okay, for initial treatment, direct oral anticoagulants, DOACs, like apixaban or rivaroxaban, are now often preferred as first line, as they don't require initial heparin bridging or regular INR monitoring like warfarin.
When might we still use heparin?
If DOACs are unsuitable, for example, in severe renal failure, eGFR 1530 depending on the DOAC, during pregnancy or breastfeeding, in patients with antiphospholipid syndrome, or sometimes in massive PE requiring thrombolysis, then we typically default to low molecular weight heparin, LMWH injections, possibly followed by warfarin.
And the standard treatment duration?
The standard treatment duration is generally 3 months for a first provoked DVT or PE, meaning there was a clear transient provoking factor like recent surgery or immobility.
What if the PE was unprovoked? No clear reason.
Yes, that's different. If the PE was unprovoked, meaning no clear risk factor identified, the risk of recurrence is higher. Therefore, the standard duration is usually longer, often extended to 6 months, and indefinite or long-term anticoagulation should be considered, weighing the risks of recurrence against the risks of bleeding.
And in unprovoked cases, we need to investigate for underlying causes, right?
Absolutely. Patients with an unprovoked VTE must be assessed for underlying causes. This typically involves age and sex-appropriate cancer screening, history, examination, baseline bloods, including FBC, calcium, LFTs, urinalysis, CXR, and further screening like mammogram, cervical smear, consideration of CT abdomen pelvis depending on age and risk, formal thrombophilia screening looking for inherited clotting disorders like factor V Leiden, prothrombin gene mutation, protein CS deficiency, antithrombin deficiency might also be considered, especially in younger patients or those with a family history, although testing is usually performed a few weeks after stopping anticoagulation for accurate results.
Okay, comprehensive approach needed for unprovoked clots. Moving on quickly to pneumothorax. What's that subtle but key cardiovascular diagnostic clue often mentioned, especially in tension pneumothorax?
Yeah, besides the obvious respiratory distress, tracheal deviation away from the affected side, and hyperresonance with reduced breath sounds on the affected side, the key cardiovascular clue you might find, particularly in a tension pneumothorax, where the high intrathoracic pressure is severely restricting cardiac filling, is pulsus paradoxus.
Explain that again.
Pulsus paradoxus is an exaggerated fall in systolic blood pressure, typically greater than 10 mmHg during normal inspiration. It reflects the impaired venous return to the right heart and the interventricular septum bulging into the left ventricle during inspiration due to the high pressures. It's a sign of significant hemodynamic compromise.
Got it. And the immediate life-saving procedure for tension pneumothorax needle decompression demands absolutely precise needle placement. And it differs for adults and children, doesn't it, due to anatomical variances?
Yes, this is a critical difference for safety. You must know this. For an adult patient needing emergency needle decompression, the standard site for inserting the large bore cannula, for example 14G or 16G, is the second intercostal space in the midclavicular line. Correction. While the second intercostal space, mid-clavicular line, was traditional, current guidelines often recommend the fourth or fifth intercostal space, just anterior to the mid-axillary line. This lateral site is now often preferred in adults as the chest wall is thinner there compared to anteriorly, reducing the risk of the needle not reaching the pleural space, and it potentially has a lower risk of injuring underlying structures like the internal mammary artery. Always follow local resuscitation council guidelines.
Okay, 4/5 space, anterior mid-axillary line for adults is the updated advice. And for a child?
For a child whose chest wall is thinner and mediastinal structures might be positioned differently, the recommended site remains the second intercostal space in the midclavicular line on the affected side. Using the lateral approach in small children might carry a higher risk of injuring underlying organs.
Okay, crucial distinction. Now, after a pneumothorax has been treated, for example with aspiration or a chest drain, and resolved, what's the crucial post-treatment rule we must enforce before that patient is allowed to fly?
The rule is very strict and clear. No flying until at least 7 days after a documented satisfactory chest X-ray confirms complete and stable resolution of the pneumothorax.
Why so strict?
Because the residual air, even a small amount, will expand significantly at the reduced cabin pressure at altitude, risking a recurrent pneumothorax, potentially a tension pneumothorax, during the flight, which would be catastrophic. Same applies to diving.
Okay. Finally, for this acute section, let's wrap up with smoking cessation, focusing heavily on the pharmacology options and their absolute safety warnings and contraindications.
Right. This is huge for preventative medicine.
Oh.
We rely on 3 primary pharmacological interventions to help people quit, alongside behavioral support: NRT, nicotine replacement therapy; varenicline, brand name often Champix; and bupropion, brand name often Zaban.
Let's talk NRT first. Lots of options there.
Yeah, NRT comes in many forms: patches, gum, lozenges, inhalers, nasal spray. Patches are often recommended for providing a steady background level of nicotine to reduce baseline cravings, often combined with the short-acting form, like gum or lozenge, for breakthrough cravings. NRT is generally safe and well tolerated.
Okay, now varenicline. Incredibly effective for many, but it has a bit of a complex starting regimen and some really important high-risk contraindications.
Yes, varenicline is very effective. It works as a nicotine receptor partial agonist. This means it partially simulates the nicotine receptors in the brain to reduce withdrawal symptoms and cravings, while simultaneously blocking nicotine from cigarettes from fully binding if the patient does smoke, reducing the rewarding effect.
And how do you start it?
You actually have to start taking varenicline 1 to 2 weeks before the chosen target quit date, gradually increasing the dose. This allows the drug levels to build up.
And the major contraindications, the safety warnings.
The major contraindications and warnings relate primarily to neuropsychiatric effects. It should be used with caution, or may be contraindicated, in patients with a history of significant mental health disorders, like depression, anxiety disorders, or psychosis. There have been post-marketing reports of mood changes, agitation, depression, and even suicidal ideation, although large trials have largely refuted a direct causal link for most people. However, caution is still advised. Other contraindications include severe renal impairment, and it is strictly contraindicated in pregnancy and breastfeeding. Epilepsy is another condition where caution is needed. Patients must be monitored closely for any mood or behavior changes.
Okay, careful screening and monitoring needed for varenicline. What about bupropion? It works on a different neurochemical pathway, doesn't it?
Yes, bupropion is actually an antidepressant medication, an NDRI norepinephrine and dopamine reuptake inhibitor that was also found to aid smoking cessation. It's thought to work by boosting dopamine and norepinephrine levels, mimicking some of nicotine's effects and reducing withdrawal.
And its specific contraindications.
Yeah. Bupropion's primary absolute contraindication is epilepsy, or any condition that lowers the seizure threshold, like brain tumors or abrupt withdrawal from alcohol or benzodiazepines, because bupropion itself can lower the seizure threshold and increase the risk of seizures.
Okay, epilepsy is a definite no-go.
Yes. Another absolute contraindication is a current or past history of eating disorders, specifically bulimia nervosa or anorexia nervosa. This is because electrolyte disturbances common in these conditions can further increase the seizure risk when combined with bupropion. Again, like varenicline, it is contraindicated in pregnancy and breastfeeding.
So if a patient is pregnant and wants help quitting smoking, what is the single safe pharmacological option?
For pregnant women, only NRT is considered safe to use pharmacologically after trying behavioral support alone. While nicotine itself isn't ideal, the risks associated with NRT are considered significantly lower than the severe risks posed by continued smoking during pregnancy, exposure to carbon monoxide, cyanide, and thousands of other toxins in tobacco smoke.
And we must counsel pregnant smokers on those severe fetal risks, shouldn't we?
Absolutely. We have to be very clear about the risks. Smoking during pregnancy significantly increases the rates of miscarriage, stillbirth, preterm delivery, and having a baby with low birth weight. It's also linked to developmental delay and specific congenital defects like cleft lip and/or palate. The toxins directly affect the developing fetal organs, including the brain, liver, and lungs, with potential long-term consequences for the child's health. Quitting smoking is one of the most important things a pregnant woman can do.
Very important message. Just a quick final note on lung cancer, reminding ourselves of the key red flags and the criteria for an urgent 2-week wait, 2WW referral, which is our primary care gateway to potentially catching it early.
Yes, the red flags for possible lung cancer that need investigation include a persistent cough, especially if changing or new in a smoker ex-smoker over 40, unexplained shortness of breath, SOB, persistent or unexplained hoarse voice, suggesting recurrent laryngeal nerve involvement, unexplained weight loss, persistent chest or shoulder pain, and of course, hemoptysis, coughing up blood. Finger clubbing is another important sign.
And the specific 2WW referral criteria. When must we refer urgently?
The NICE guidelines for suspected cancer referral are quite clear. You must make an urgent 2WW referral for suspected lung cancer if the chest X-ray findings are suggestive of lung cancer, example, suspicious mass, consolidation that doesn't clear, pleural effusion, hilar enlargement. Or if the patient is age 40 or over with unexplained hemoptysis. Even if the initial CXR is clear as someone over 40 with hemoptysis, they usually still warrant urgent referral for further investigation like CT or bronchoscopy. Other criteria involve combinations of symptoms in smokers over 40. Okay, so we dedicate this final section to just reinforcing some of those nuanced diagnostic criteria and pointers to details that really help you distinguish between complex diagnoses when you're faced with a clinical scenario, perhaps in the exam or in a tricky consultation.
Let's look first at pleural effusion fluid around the lung. Analyzing the fluid itself is absolutely key to separating simple fluid backup, say from heart failure, from something more sinister like infection or malignancy. We use the protein content primarily to distinguish between a transudate and an exudate.
That's the fundamental first step with pleural fluid analysis, yes. We measure the protein concentration. A transudate is defined as having a low protein content, typically less than 30 grams per liter, GL.
And what causes a transudate?
The cause of a transudate is usually systemic and non-inflammatory, originating outside the lung cavity itself. It's typically related to imbalances in hydrostatic pressure, pushing fluid out of capillaries, or oncotic pressure, low protein pulling fluid in. Classic causes are congestive heart failure, liver cirrhosis, leading to low albumin and portal hypertension, nephrotic syndrome, where protein is lost via the kidneys, and sometimes peritoneal dialysis.
Okay, low protein, systemic cause, transudate, and the exudate.
An exudate is defined by a high protein content, traditionally greater than or equal to 30 GL. The cause here is usually local, inflammatory, or infectious, originating within the lung or the pleura itself. It happens because inflammation increases capillary permeability, allowing protein-rich fluid and cells to leak out.
And the causes of exudates?
Common causes of exudative effusions include pneumonia, called a peritonic effusion, empyema, pus in the pleural space, cancer, lung cancer, mesothelioma, metastases, pulmonary embolism, tuberculosis, and inflammatory conditions like rheumatoid arthritis or lupus.
So, high protein, local inflammatory cause, exudate. Are there more detailed criteria?
Yes, for cases where the protein level is borderline, around 25-35 GL, we often use Light's criteria for a more precise distinction. This involves looking at the ratio of pleural fluid protein to serum protein, exudate of 0.5, the ratio of pleural fluid LDH, lactate dehydrogenase, to serum LDH, exudate of 0.6, and whether the pleural fluid LDH is more than 2/3 the upper limit of normal for serum LDH. If any one of Light's criteria is met, the fluid is classified as an exudate. LDH is a marker of cell turnover and inflammation.
Okay, Light's criteria for the borderline cases. Let's revisit finger clubbing now. It's the ultimate systemic sign, really. We need to remember that long list of respiratory causes, but always keep the potential systemic links in mind too.
Absolutely. Finding new finger clubbing, that bulbous swelling of the terminal phalanges and loss of the nail bed angle, Shamroth's sign, demands thorough investigation. The major respiratory causes we need to rule out include primary malignancies. Lung cancer is a big one, especially non-small cell types like adenocarcinoma and squamous cell.
What else in the lungs?
Severe chronic suppurative lung diseases, things like lung abscess, empyema, advanced bronchiectasis, especially associated with CF, and cystic fibrosis itself. Also, restrictive interstitial lung diseases like idiopathic pulmonary fibrosis or fibrosing alveolitis. Basically, conditions causing chronic lung inflammation or hypoxia.
Okay. What about the important non-respiratory causes that might fool us if we only think about the chest?
Yes, you always have to look outside the chest. Important GI causes include advanced liver cirrhosis, particularly primary biliary cirrhosis. Inflammatory bowel disease, IBD, especially Crohn's disease, can be associated with clubbing. Sometimes celiac disease, too.
And cardiovascular.
Cardiovascular causes include cyanotic congenital heart disease, right-to-left shunts, and infective endocarditis. Very rarely you might see it with thyroidopathy, related to Graves' disease or even familial clubbing. The take-home message is, never assume clubbing is benign until the major underlying causes, particularly lung cancer and chronic lung infection fibrosis, have been thoroughly excluded.
Wise advice. Finally, let's just solidify those specific vasculitis syndromes that often present with that dangerous, potentially fatal pulmonary renal overlap. These are key diagnostic patterns.
Yes, these systemic vasculitides are critical to recognize because they often require urgent immunosuppressive treatment to prevent irreversible organ damage. Let's start with granulomatosis with polyangiitis, GPA, which used to be called Wegener's granulomatosis.
What are the hallmarks of GPA?
GPA is typically associated with a positive CANCA blood test, cytoplasmic anti-neutrophil cytoplasmic antibodies, usually targeting proteinase 3. Clinically, it involves a classic triad. 1. Upper respiratory tract disease, think chronic sinusitis, epistaxis, nosebleeds, nasal cresting, sometimes leading to a saddle nose deformity. 2. Lower respiratory tract disease, lung nodules, cavities, and often pulmonary hemorrhage causing hemoptysis. And 3. Kidney involvement, typically a rapidly progressive glomerulonephritis causing hematuria, proteinuria, and renal failure.
Okay, CNNCA positive, upper-lower airways, kidneys, GPA. What about the one characterized by severe asthma and eosinophilia?
That would be eosinophilic granulomatosis with polyangiitis, EGPA, which used to be called Churg-Strauss syndrome.
What defines EGPA?
EGPA is defined by a background of severe, often late-onset asthma, peripheral blood eosinophilia, very high eosinophil count, and often chronic rhinosinusitis or nasal polyps. The vasculitis phase can then affect various organs, commonly causing skin lesions, purpura, nodules, peripheral neuropathy, for example, mononeuritis multiplex, myocarditis, and sometimes lung infiltrates or glomerulonephritis, though kidney involvement is often less severe than in GPA. EGPA is often associated with a positive PANCA test, paranuclear ANCA, usually targeting myeloperoxidase, MPO, but not always.
Asthma, eosinophilia, sinusitis, maybe pan-CA, EGP, Churg-Strauss, and the third one, Goodpasture syndrome.
Goodpasture syndrome, or more accurately, anti-glomerular basement membrane, anti-GBM disease, is slightly different as it's caused by antibodies directly targeting a specific component, type IV collagen, of the basement membrane in both the kidney glomeruli and the lung alveoli.
So it hits lungs and kidneys directly.
Yes. This leads to a potentially disastrous combination of pulmonary hemorrhage, often presenting as massive hemoptysis, and rapidly progressive glomerulonephritis, leading quickly to renal failure. It's an autoimmune emergency requiring urgent treatment with plasma exchange to remove the antibodies, and potent immunosuppression, like cyclophosphamide and steroids. ANCA tests are usually negative in pure anti-GBM disease.
Okay, anti-GBM antibodies causing hemoptysis and renal failure. Good pastures. Got it. Well, we have certainly dissected an immense volume of material today. We've really moved beyond just the basic facts into those critical numerically defined criteria that underpin safe and successful clinical practice in respiratory medicine. The specific FEV1 cutoffs, the phenometrics for kids versus adults, the CURB-65 score for pneumonia severity, the precise safety warnings for smoking cessation drugs. Clinical certainty really relies on the instant recall and correct application of these exact parameters, doesn't it?
It absolutely does. You need that information at your fingertips. And perhaps my final thought for you, our listeners, as you consolidate all this intense knowledge, remember that the lung is so often the canary in the coal mine for underlying systemic disease. Use those highly specific diagnostic connections we discussed, the pneumonia plus hyponatremia pointing to Legionella, the upper versus lower lobe fibrosis patterns hinting at different causes, and that long list of causes for finger clipping. Use these as your constant reminder to always think broadly and look outside the chest when formulating a complex diagnosis. If you view the body as interconnected as it truly is, you'll be much better placed to catch those diagnoses that others might miss.
That's an excellent point to end on. That comprehensive analytical review wraps up this high-yield deep dive into respiratory medicine essentials. Commit these numbers, criteria, and pathways to memory, and keep refining your clinical judgment. We'll catch you next time for another deep dive.